So if you're in a position where you have an oropharyngeal airway in, possibly nasopharyngeal airway in, and you're applying bag valve mask ventilation to your patient who is had airway obstruction or not breathing effectively, you may want to use alternative devices, sort of advanced airway devices, such as the supraglottic airway device. So the advantages of supraglottic airway devices are that it can allow you to administer breaths to your patient as an alternative to bagging the patient or bag valve mask ventilation with an ambu bag, for example. What supraglottic airway devices essentially are, it's a tube with a cuff at the end. The cuff is soft but rigid enough so it can be placed just above the glottis at the larynx, and it allows positive pressure ventilation to be administered in a reasonably safe way. The thing to remember about these is that it's not a definitive airway, although it does offer a degree of airway protection. It's not a definitive airway in the same way a cuffed endotracheal tube would be. So the way to insert an eye gel, there is a described technique to doing this. So first of all, you need a patient who's going to be unconscious enough to tolerate it. But if breathing is ineffective and your patient's tolerating an oropharyngeal airway or needing further rescue maneuvers with bag valve mask ventilation, they're likely to be in a position where they would tolerate a supraglottic airway device. So I would make sure that the airway is almost unobstructed as possible. It often helps to have an assistant to apply a jaw thrust, which will move the soft tissues out of the airway and open the mouth. I would hold the device like a pen, and I would go over the top of the incisors and around the corner until you feel resistance around about the pharynx. And it usually kind of sits home. And at that point, when you're at a point where you've met resistance, I would try and apply positive pressure ventilation using an ambu bag. And at that point, you're looking for all your normal endpoints of effective ventilation. So looking for misting of the tube, you're looking for effective chest rising, and you're hopefully maintaining your oxygen saturations at that point as well. So end-tidal CO2 monitoring is a very useful adjunct to patients that you're administering positive pressure ventilation to. Things to remember about it: it can give you an idea of the effectiveness of the breaths you're giving your patient, and it's also a surrogate of cardiac output. If you've got no cardiac output, then you won't have any CO2. There are lots of different devices to measure end-tidal CO2. But they all work in a similar way. So they are measuring expired gases. So if you think about the way that you breathe oxygen in, it enters your lungs, the interface there between your alveolus and your pulmonary capillary. Oxygen is transported to your tissues, the metabolic reaction there. At that point, carbon dioxide is liberated. It's picked up by hemoglobin, delivered back to your alveolus, and then you breathe it out. So that is your end tidal so-called carbon dioxide tension, which is really coming from your carbon dioxide tension in your blood. So the things that it's useful for, so it can be used to give you an idea of the adequacy of the airway device you've got in. That could be, simply bag valve mask ventilation, or it could be with a supraglottic airway device that you've inserted, or it could be indeed with a tracheal tube. And indeed, we would use in anesthesia and intensive care would use carbon dioxide monitoring as a routine, and it's indeed a recommendation. ALS would describe using end-tidal carbon dioxide monitoring as a useful adjunct when administering chest compressions, because of the fact that it gives you a representation of cardiac output and thus gives you an idea of the adequacy of CPR or chest compressions. If you have a poor cardiac output, or the chest compressions are not adequate, or the healthcare provider delivering chest compressions is getting tired or fatigued, then you may even see the end-tidal carbon dioxide levels decrease. During CPR, you'd expect to see an end-tidal CO2 concentration certainly greater than 1. As the cardiac output improves, you'd expect to see that number rise, and after return of spontaneous circulation, you might see that end-tidal CO2 value rise to levels that you would see in normality. So if you're delivering breaths to your patient, or indeed got a patient in cardiac arrest, I'd be concerned if you're not registering end-tidal CO2 waveform or measuring end-tidal CO2. So there's a growing body of evidence that suggests in the pre-hospital setting the best and safest way to administer positive pressure ventilation is using a supraglottic airway device. Having said that, in the presence of the correct skill set and conditions, placing a definitive airway may be the best thing to do for your patient. The definition of a definitive airway is a cuffed tube in the trachea with the cuff inflated. What that means for your patient, however, is embarking on a procedure that requires a considerable amount of training and also maintenance of that training to do it in a safe way. The advantages are that it does protect your airway against airway soiling. The cuff that you inflate in the trachea will protect the soiling of your airways and the patient's lungs from gastric contents, and clearly that's a very safe place to be. So to place an endotracheal tube, usually use a device called a laryngoscope. So laryngoscopes come in various shapes and sizes. Quite often we would use video laryngoscopy in challenging cases in the in-hospital setting and also in the pre-hospital setting too, if available. One important consideration during laryngoscopy is the position that you would let your patient in. So quite often we embark on laryngoscopy after a head tilt and a chin lift, those basic airway maneuvers. One thing to take care of in patients in the pre-hospital setting would be patients with cervical spine injury. And they would need a laryngoscopy whilst their head and neck is stabilised in a process called manual inline stabilisation. This can present some challenges because the natural movements that you would usually administer to help visualise the larynx with a laryngoscope is altered. So this is a skill that needs to be practiced.
When all other options have failed and you can no longer successfully oxygenate your patient using any of the simple adjuncts we've discussed, the simple airway maneuvers, or an iGel or intubation is not possible, you might need front of neck access or a surgical airway. This involves gaining access into the patient's trachea through the front of their neck and is a last-ditch attempt in order to oxygenate your patient when all else has failed. In order to do this, you only need 3 things. You need a scalpel, a bougie, and a size 6 ET tube. This should only be called for when you've called for other help, or you know that help's on the way, ideally, and should be done by a qualified physician who has done it before and knows what they're doing.